يعطيكم العافية. طبعا احنا رح نبتدأ السيشن الثاني خلال 5 دقائق، ورح نبتدأ السيشن في إعلان النتائج للفائزين بالجوائز عن يوم أمس. فرح نستنى كمان تقريبا 4 دقائق وبعديها نفتح السيشن. موجودة؟ جهتكم موجودة هون عشان الله تشوف لي إياها. استنى عن دقيقتين بس. طيب احنا يعطيكم العافية جميعا. راح شوي نأجل إعلان الجوائز لبعد هذا السيشن بناء على طلب رئيس المؤتمر. راح يكون ما بين السيشن الهيباتوبيلياري وسيشن المultidisciplinary team. So I would like again to start the the oncological diversity session now. I think the oncological diversity session is one of the most important sessions in this conference. The main reason I'm saying this because it does combine several oncological subspecialties under one umbrella. So I would like to welcome all of Dr. Sultan Masleh, Dr. Bashar Jaber, and Dr. Fuad Nafa, and Dr. Marwan Abu Farah, who will moderate the next session. And I will ask Dr. Sultan to start this session by inviting the first speaker. Thank you very much.
مساء الخير جميعا. نبدأ السيشن إن شاء الله. The first presentation will be from King Hussein Cancer Center with the chairman of the pediatric department at the Kshcc, one of the senior pediatric hematologist oncologist consultant, Dr. Iyad Sultan. His talks today about the bills of the managements of the pediatric malignant abdominal masses. Dr. Iyad, go ahead.
يا جماعة صوتي واضح؟
عليكم السلام. واضح الصوت دكتور. شو مساء الخير ويعطيك العافية.
الله يعافيك.
يعني احنا كثير فخورين بوجودك معنا اليوم دكتور إياد. one of my teacher. طبعا الفضل لله والفضل لمركز الحسين لما احنا فيه اليوم إن شاء الله.
طيب thank you everybody for the invitation. سامع شوي صبر. I don't know. Anyway. So, change the title. Because in the diagnosis of orthometabs in children, الصحيح إنه it's difficult when you don't know your practice very well. Or I don't know how many of you are pediatric oncology, but I made it more general, hoping that we would benefit command instance for students who don't work in this field all the time. So, I start by showing you some data from registry. This is from 2006 to 2021. We had 614 children who were treated at our center with malignant abdominal tumors. The median age was 2 for those patients, and there was an almost equal distribution of males and females. Almost half of the patients who came to us were metastatic, which is kind of more than what you expect for this patient. This is the number of patients who come every year, and you can see over the past maybe 8-9 years, we had more patients, maybe because of the number of Syrian refugee children who are now in Jordan. The most common diagnoses are neuroblastoma, Wilms tumor, followed by other embryoidal tumors, mainly hepatoblastoma, and then non-Hodgkin lymphoma and rhabdomyosarcoma. So these 5 are the 5 most common malignant abdominal tumors. In Kshcc, the outcome is the 5-year survival for all patients who present with abdominal tumors are 61%. But if you compare it to the SEAL in terms of the metastasis, you can see that we have more metastatic tumors. So the outcome is kind of worsened by the higher number of patients with metastatic disease. For localized and regional tumors, the outcome is acceptable, but for metastatic patients, of course, it's below 50%. Because of the high number of metastatic patients, the outcome for the whole group. We studied 200 patients who come to Kshcc over the past 3 years. Fever was the most common presenting finding, followed by bone pain, mass, and headache. But if you look at solid tumors, feeling a mass was the most common finding at presentation. The median time from onset of symptoms to starting treatment at Kshcc, and remember that Kshcc receives the majority of patients with children with cancer in Jordan. The median time for all patients was 47 days. For patients with brain tumors, it was longest, followed by solid tumors. So, more than 2 months from the onset of symptoms to starting treatment at the center. This is still acceptable, but for patients with bone tumors, but in particular, there's more delay in diagnosis and starting treatment. For patients with leukemia, it's less than a month, which is something that we should be proud of. So again, the median time from the onset symptoms to treatment, starting treatment was 57 days. And interestingly, there was no blame on families, because in most cases, sought medical advice within the first month.
Dr. Riyad, sorry for interruption. The slides is not moving. نفس السلايد الأول. إذا في مشكلة عندك في السلايدات.
طب لو تحتوني يا جماعة. طيب هيك شايفين؟
إذا معك كمان هي extra 2 minutes just for you. Okay.
هيك moving.
تمام.
هيك moving.
صحيح.
Do you see the slide now?
Yes.
طيب هلا do you see the slide or still the first slide?
لا هو موجود السلايد. Okay, go ahead.
طيب هيك moved. تحركت؟
لا ما تحركت.
اوكي انا خليني معناته ما بعرف شو المشكله، بس انا اول معناته بريزنت من الفايل نفسه. I don't know what's the problem.
تعمل شير للسكرين اذا كان على الزوم.
انا عامل شير الهول سكرين. جود ايديا. طيب well خليني اشوف. اوكي share the whole screen. Okay, do you see the survivor care?
صحيح. Okay.
Okay, now it's moving.
Moving, right.
Nice. Okay, so السلايدات راحت عندكم يا جماعة. وهون this is our delay. This is زي ما كنا موصلين هون وحكينا التوتال delay media is 47 days. Okay. هلا خلينا نبدأ بالأشياء المهمة. Wilms tumor is the most common renal tumor in children. 90% of renal tumors in children are Wilms. It's the 6th most common cancer in children. Male to female ratio is almost equal, except for patients with bilateral tumor where females are predominant. 3/4 of patients are diagnosed with 1 and 5, so these are toddlers. 1% are familial, 10%, and maybe more if you examine the patients carefully have some sort of congenital anomalies. Treatment in general for Lymph tumor follows two pathways. In North America, they do nephrectomy first, and then this is followed by chemotherapy based on histology. In Europe, the same approach is to start with 4 to 6 weeks of chemotherapy, followed by nephrectomy, and then followed by more chemotherapy based on response, histologic and radiologic response. We at Kshcc follow the same approach. We feel it's safer, it's easier for the surgeons, it's more convenient for the family, and I think the outcome at the end is the same. This is a baby with omphalocele, large tongue, so this is a big with Widman syndrome, which can be associated with hemihypertrophy, and in both cases, whether associated with hemihypertrophy or not, those patients are at increased risk of developing embryonic tumors in the liver and kidney. So those patients need screening until the age of 6 or 7 with ultrasound and ultra-fetal protein monitoring. Absence of iris or aniridia can be associated also with Wilms tumor. The typical syndrome is Wilder syndrome, where you have aniridia, genital anomalies, mental retardation, and Wilms tumor. Wilms is highly curable thanks to its chemosensitivity and also in some cases radiosensitivity. So a patient who comes very advanced like this may be cured and have almost a normal life with no future complications. These tumors grow rapidly, so it's not uncommon to see patients who present with extremely large tumors at presentation. The hallmark, the radiologic sign is the close sign. You can see that this tumor originates from the kidney, and these horns here indicates that this is a close sign, the kidney origin. Radiologists also look to the IVC, other kidney for lesions, renal veins, and metastatic lesions in the liver, and of course the chest CT scan for metastatic lesions. This is another close sign typical for Wilms tumor. When you see this, you know this is a renal tumor. So CT scan is now the standard of care for radiologic assessment for metastasis. Some metastasis, especially when it's below 2 to 5 centimeters, it cannot be seen on the X-ray. So we need really to get the chest CT scan at diagnosis for all patients with Wilms tumor. Sometimes lesions are metastatic lesions like this, called cannonball metastasis, can occur in Wilms tumor and other tumors as well. Histologic appearance is classically called the triphasic histology, and you can see endothelial differentiation where you can see the what resembles fetal tubules, round blue cells, which is called blastema, and then stromal component. So this is called a classical triphasic histology of Wilms tumor. In some cases, you have bilateral disease like this, and you can see the bilateral close signs. These patients are challenging to treat because you don't want to sacrifice both kidneys. You can, what we do, and this is critical, needs to be done in a multidisciplinary settings where oncologists, radiation oncologists, and surgeons speak to each other and plan the management with nephron-sparing surgery to salvage both or at least one kidney. Not everything bilateral is Wilms, so this is a rhabdoid tumor actually. Once I can see this is tumor originating from the hymen of one kidney, and this is a kidney that's almost replaced by rhabdoid tumor. Rhabdoid tumor is a very malignant tumor, and those patients have a chance of cure that's way below Wilms tumor. So I'm going to move to neuroblastoma, and if I ask you what is the most common malignancy in children, I think everybody will know it's leukemia. But if I ask you what's the most common killer in childhood cancer, the answer, of course, is high-risk neuroblastoma. So neuroblastoma comes in two flavors. It comes in low intermediate risk tumors where they need minimal treatment, and half of patients present with high-risk disease, typically in patients more than 18 months, with metastasis to the bone and bone marrow, and with MYC amplification. And those patients with high-risk disease need treatment with multi-agent chemotherapy, stem cell harvest, autologous bone marrow transplantation, surgery, radiation, and this is all followed by high doses of cis-retinoic acid to differentiate the residual cells, as well as immunotherapy, anti-GD2 antibodies when it's available. The chance of a cure is 50% with autologous transplant. It can go up to 50 to 60% with anti-GD2 antibody, which is currently not available for everybody. Actually, it's available for only 15% of children all over the world because of the extremely high cost of this treatment. The most common site for neuroblastoma is the adrenal and retroperitoneum, followed by posterior mediastinum, and then you have cases of cervical and neuroblastoma all along the sympathetic chain, as these tumors originate from the neural crest. So how do we know if the disease is low or high risk? First, we start with histology, and the pathologists invented this scheme to stratify patients based on grade of differentiation, the stromal component, the age of the patient, the MKI index, which is the mitotic karyoretic index, measured on 5,000 cells, and then the pathologist will tell you this is favorable or unfavorable. After that, the age of the patient, the histology, and then some molecular stratification. Most important is the MEK-N gene amplification. The MEK-N gene is a gene present on the short arm chromosome 2. You should have 2 copies in each cell on each short arm chromosome 2, but in certain neuroblastoma and other tumors as well, you have amplification. Clinically significant if you have more than 10 copies, sometimes you have hundreds, thousands, or more than that, and sometimes the short arm chromosome 2 will separate and form a microsome. So MEK-N gene amplification is now and forever the most important significant prognostic factor. There are other molecular markers that we can test for, but really nothing comes close to MEK-N gene amplification in terms of prognosis and stratification for treatment. Okay, some babies like this early in life, maybe at birth, with metastasis to the liver or skin or bone marrow. And this is the classical stage 4S disease. Those infants, interestingly, undergo a process of spontaneous regression, where the tumor, the primary tumor as well as metastatic lesion, disappear without chemotherapy. We still may lose some of those patients who present like this with massive hepatomegaly because of respiratory compromise, but 80% of the patients will make it without major treatment or minimal chemotherapy, just to buy time until the tumor starts differentiating. MIBG is an important modality of scanning. You can see bone metastasis in this patient before starting chemo and how they disappeared afterwards. Nowadays, we use more of PET scan with a PET FDG PET or DOTATOC PET because it gives better resolution and more sensitivity. Horner syndrome, we have unequal pupils, as you see. Ptosis is another characteristic finding in patients with cervical neuroblastoma. Recently, I had a patient who went from one ophthalmologist to the other without a diagnosis until one ophthalmologist took the neck and found cervical tumor, which turned out to be well-differentiated favorable neuroblastoma, completely resected, and the patient was cured. In some cases, typically in high-risk patients, you have raccoon eye metastasis, where you can have orbital bone metastasis. Manifesting raccoon eye can be severe as this, and this is typical for high-risk patients with metastatic bone, metastatic neuroblastoma. This is a well-circumscribed tumor, adrenal tumor with calcification. This tumor that can be easily resected by an expert surgeon, and this is another flavor of low-risk neuroblastoma with or without bone metastasis without MEK-N gene amplification. But this is how a risk tumor looks. It's huge. It invades the midline, goes around the vessels. It's intending the kidney, and this is not a closide, of course. This is how a high-risk neuroblastoma looks like. Unresectable tumor, we hope by chemotherapy to shrink a tumor like this and try to resect most of this tumor to cure the patient.
Dr. Riyad, 1 minute more.
Okay, Burkitt's lymphoma is a fast-growing tumor, may manifest with tumor loss at presentation. Some patients come with malnutrition, which makes this complicated. LMB regimens A, B, C are where the patients fight group from B and C are the standard treatment. Rituximab is recently added with hopes to improve the outcome. This is a Burkitt's lymphoma. The abdomen, unlike African type, where patients present with jaw tumors, most of patients in our region and all over the world present with sporadic Burkitt's lymphoma. Both are EBV related and both share the histologic appearance of starry sky appearance. We have macrophages and background of background cells. Hepatoblastoma, just a couple of words about hepatoblastoma, is the most common primary liver tumor. It presents typically with abdominal mass, with high alpha-fetoprotein. We do not get biopsies for babies 6 months to 3 years with high alpha-fetoprotein because there's a risk of bleeding and significant morbidity or mortality. The treatment, again, similar to when starts with upfront surgery or upfront chemotherapy. We go with the upfront chemotherapy. This hepatoblastoma usually is a single lesion, unlike hepatocellular carcinoma, which is multiple lesions. Genetic stratification or classification is important to plan further care and to check for resectability, which happens typically after 4 cycles of chemotherapy. We use cisplatin monotherapy because the Cytoid group of that cisplatin is as good as Play-Doh regimen, cisplatin plus doxorubicin, and nowadays we add sodium thiosulfate, which is a cheap medicine, but it prevents the cisplatin-induced hearing loss. For high-risk patients, i.e. metastatic patients or unresectable tumors, we use Cytoid-4 regimen with cycles, those dense cycles of cisplatin and doxorubicin, followed by carbodox.
Thank you, Doctor. Thank you.
Allah, thank you.
See you later. Move to the next speaker, also from King Hussein Cancer Center, one of the distinguishable speaker in the pediatric leukemia, Dr. Amal Abu Ghosh, a pediatric hematologist consultant at Kshcc. Her talk about pediatric leukemia update in the diagnosis and the management. Start.
The era where leukemia can be cured without chemotherapy, maybe it is possible. So we will just have to wait and see. And thank you very much, Ma.
Start from the start, please.
صباح الخير، شكرا لدعوتي للمشاركة في هذا الاجتماع. My talk today will be about pediatric acute lymphoblastic leukemia. I'm going to discuss current therapies and the growing role of immune therapy. So the talk will be summarized as an overview of ALM, talking about clinical presentation and diagnosis, the workup, risk-adapted therapy, and finally immune therapy, followed by a summary and conclusion. Leukemia or cancer in children compared to adults is very rare, and it accounts for 1% of all cancers for children aged less than 20 years of age. Also, mortality from cancer compared to the adult population is also very low. It accounts for about 0.3% for pediatric kids less than the age of 20 years. Leukemia is the commonest childhood cancer compared to brain tumors, non-Hodgkin's lymphoma, Hodgkin's, thyroid, and the rest. It accounts for about 24.9% of all childhood cancers. So in the United States, from the SEER-12 data statistics, they accounted for about 4.9 new cases of acute leukemia per 100,000 children per year. And as you look at the graph, the rate has been relatively stable over the past 4 years. As for the mortality rate from childhood cancer, it has been steadily and slowly declining, accounting for 0.5 per 100,000 children per year. Survival from childhood leukemia is really excellent. It's around 85.8% 5-year survival, and that includes all types of leukemia together. Now, regarding leukemia, there is a peak incidence between the ages of 1 and 4. It's less common below 1, and then gradually declines as the kids get older. But the peak is between 1 year to 4 years of age. Now, the childhood leukemia, the death from childhood leukemia is commonest among oldest kids between the ages of 15 to 19, and that is explained by having the higher risk of leukemia in this age group and higher treatment failures and relapse. Where does leukemia come from? It arises from the stem cells that give rise to the lymphoid series of cells or to the myeloid series. So there will be some sort of decrease in cell maturation, impaired apoptosis, and that results in over expansion of the blasts, either at the lymphoblast, which leads to the acute lymphoblastic leukemia, and it could be B lymphoblastic, which is the commonest one, accounting for 85% of all ALL leukemias, or it could be T lymphoblastic leukemia, which accounts to 15% of all ALL. The other group is the myeloblast and leads to development of AML, which we will not be discussing today. So what have we learned from the past decades of treating leukemia? I'm going to come across the clinical trials and outcome, the risk-adapted therapy, cytogenetics of this leukemia, and the response to therapy. Regarding the leukemia risk and the survival, it has been shown through multiple oncology groups, whether the COG, the POG, the St. Jude, that the lower risk leukemias are the ones that have the better survival, while as the risk of leukemia increases, the risk of relapse increases and the survival decreases. And you can see that in the panel on the left-hand side. Also, we've seen that the B-cell leukemia usually fares better than T-cell leukemia, as seen on the right-hand panel. Also, we've learned over the past decades that leukemia, lymphoblastic leukemia, is not one entity. It's a very diverse group, and there are so many mutations that we can detect there, either in the form of translocations, changes in chromosome number, aberrations that result in either leukemias that are sensitive to chemotherapy and carry a very high cure rate, or leukemias that are resistant to therapy and result in treatment failure. So if you look at the graph here and at the diagram here, you see in the teal blue color, the commonest translocation, the ETV6-RUNX1, that accounts for 22% of childhood leukemia, and that happens mostly in the NCI standard risk with the highest cure rate. You see 20% are hyper-diploid, that also carries a very good cure rate and occurs mostly in the low-risk leukemia or NCI standard risk. MLL gene rearrangement happens in 6% of the leukemias, and it's common in infants and carries a very poor outcome. The TCF3-PBX1 increases the risk for relapse. That's why once we see it, we upgrade the therapy. BCR-ABL, or the Philadelphia chromosome, in the past used to carry a dismal outcome, and most kids were taken to transplant. But with the development of TKI inhibitors, the outcome is the same as with high-risk leukemia. Other hypodiploid leukemias are really poor. IL-21 increases risk of relapse. And then in the yellow, you see the BCR-ABL-like mutations that require TKI inhibitors. In red, you see the translocations and genetic changes that happen with T-cell leukemia. And anyway, with T-cell leukemia, we usually treat them as high-risk leukemias. So looking at these genetic changes and survival, these graphs are from the St. Jude experience with leukemia, and they have shown that kids who have the hyperdiploid or the 1221 translocations, they have the best outcome compared with the event-free survival with kids with the BCR-ABL, which was around 45%, and that was prior to TKI use, and the MLL gene rearrangement that carried the worst outcome. So these genetic aberrations really impact your event-free survival. The other thing that have been studied over the years is the response to therapy, because it doesn't matter if the leukemia has good genetics or not. If you are unable to clear the leukemia fast enough, then this leukemia is resistant and treatment failure is high. How do we measure that? Is by looking at the level of minimal residual disease at different time points during the initial 4 weeks of therapy, which is called induction. So we look at 2 weeks or 1 week in other groups, and at the end of induction. And it has been shown through multiple cooperative groups, and here these are the results from the St. Jude's trials, that if you have positive MRD at the end of induction, your chances of relapse increase with the level of MRD. So if it was more than 0.1%, you are likely to have a 91% relapse rate. If it is less than 0.1 but above 0.01, it is 22% chances of relapse rate, and if it is negative, meaning less than 0.01% MRD positivity, your chances of relapse is 14%. And why is this important? It's important because then we can perform the risk-adapted therapy, which is based on these variables, whether genetics, response to therapy, B or T, phenotype of the leukemia, the NCI risk group, so that you are able to intensify therapy early on in order to decrease the negative effects of these risk factors. Here at the King Hussein Cancer Center, we have been looking at all these variables combined, and this is how we rate our leukemia from very low risk, standard, and high. It looks very busy, but it's really simple. We look at the NCI risk group, the genetics, whether favorable or unfavorable, the MRD level, and whether they have CNS or testicular disease. Presence of CNS or testicular leukemia makes them either standard or high risk. They cannot be low risk with the presence of CNS3 status or testicular leukemia. Now, clinical trials have proven very effective in treating pediatric cancer, and especially in the leukemias, because what happened over the decades is that we learned from these trials. We standardized therapies, we intensified therapies in groups where needed to be intensified. So if we look at these graphs from the St. Jude clinical trials from the 60s through the early 2000s, you will see that both the event-free survival and the overall survival has drastically increased from about 10% if you were unfortunate to be diagnosed in the 60s to more than 92% if you were diagnosed in the 2000s. And why is that? It's because of improving chemotherapies, adding combination chemotherapies, giving intrathecal and spinal chemo, and improvement in the supportive care. The Children's Oncology Group also showed improvement in survival across time frames from the 90s through the early 2000s, also proving that with time, the survival of leukemia has improved. At the KHCC, we looked at our group of patients with lymphoblastic leukemia from 2006 to 2020. We looked at 638 patients, and their overall survival was also similar to what was seen historically. And also we have seen that we have been progressively improving our survival with time. We also noticed that the high risk fares poorer than the standard and the low risk patients. And we've also shown in the graphs there that B cells do, of course, better than T cell leukemia. So now where do we go from here? We know we're doing better. So what about patients who failed their therapy? And that is where the field is going into immunotherapy and targeted therapy. So in this part of the presentation, I want to briefly describe the monoclonal antibodies, monoclonal antibody drug conjugates, bispecific T-cell engagers, BiTEs, and chimeric antigen receptor T-cell or CAR T-cell. So these are the use of immune therapies are revolutionized the treatment for leukemia. And with these medications and agents, you are engaging the patient's own immune system in order to fight and increase the clearance of these lymphoblasts. And with these agents, you either target B-cell antigens or T-cell antigens. And the common ones are the CD19, where you can use blinatumomab as a BiTE, or CAR T-cells. We have the CD22, where you use an antibody drug conjugate inotuzumab or CAR T, the monoclonal antibody against CD20, rituximab, and on your right-hand side, you see all the targets for T-cells. Some are still in preclinical trials or early clinical trials and development. I'm going to talk now about the inotuzumab osigomycin, which is a monoclonal antibody conjugate. It attacks the CD22 monoclonal, it's an anti-CD22 monoclonal antibody with kalishamycin. What kalishamycin, once this product is phagocytosed by the leukemia cells, the kalishamycin will directly damage the double-stranded DNA and causes cell death. Earlier trials were, of course, with adults, and this trial is the INNOVATE trial used for adults with refractory relapse CD22 positive ALL, and they showed that compared to patients who were treated with standard chemotherapy, their survival at 2 years was improved to 22.8% compared to 10%. Same thing, the CR or CR with hematological no recovery in the blood counts was also significantly better, 73 compared to 35%, and the progression-free survival was prolonged from 1.7 months to 5 months. And that enabled around 44% of patients who were treated with inotuzumab to go to transplant, which was the goal of therapy anyway. And as a result, it got FDA approved for relapse refractory CD22 positive ALL. What about pediatric trials? We always lag behind. So there were 51 pediatric patients who used inotuzumab on compassionate use. And those kids had CD22 positive refractory ALL. Their event-free survival and overall survival at 12 months was impressive at 23% and 36%. And 21 patients, almost half of them were able to go to bone marrow transplant, but at the expense, one of the side effects of it is SOS, which occurred in around 52% of the patients. This was followed by the COG-AALL 1621 trial using inotuzumab for CD22 positive relapse refractory precursor B-ALL. And they found that around 58.3% of the...
Time out. Got the presentation. Okay. Thank you, Dr. Amal, for her excellent presentation. We'll move to the next speaker, also from the King Hussein Cancer Center, Dr. Anwar Al-Nasan. She is a consultant of pediatric hematology oncology at Kshcc with many years of experience in and contribution to the pediatric palliative care established. Her talk today about the establishing pediatric palliative care program in low and middle income country. Welcome, Dr. Anwar. Go ahead.
السلام عليكم ورحمة الله. شكرا للاستضافة. بس وين احنا شير ذا سكرين؟ طبعا احنا بدنا نحكي عن موضوع very sensitive right now اللي هو عن establishing pediatric palliative care service, which is a very important subject for everybody and for especially in our region. To start with, I would like to give you a case اللي هي بعدين we discuss about it. A 2-year-old girl presented with leg pain and swelling. She was found to have a lytic lesion with a pathologic fracture. She was diagnosed with metastatic high-risk neuroblastoma and referred to Kshcc. Patient received multimodal treatment, chemotherapy, surgery, allo-BMT, auto-BMT, radiation, cisretinoic acid. 6 months after finishing the treatment, patient started to have leg pain and mandibular pain, same as presentation. Both scan and MIBG didn't show solid evidence for viable metastases. After 6 weeks, pain progressed, leg and mandibular masses became evident by physical examination, and palliative team was consulted. Now, to discuss this case in particular, for the palliative team and for the family and for the entire institution, we have challenges. The first challenge, which is very important, is the family distress, which is a very unexpected outcome after finishing long, exhausting treatment, and so they will be in denial. Also, for diagnostic uncertainty, at first there was only pain, the scans, they were not showing anything, then a mass appeared. Also, very important, the primary physician reluctance for referral, because as primary physician, they wish that they could cure every single patient that they encounter. And establishing a relationship with a new team at a time of difficulty. Of course, it's very difficult to talk to these families when they are in shock and in denial. And of course, the most important thing also to deal with is the pain management for this patient. The other challenges that we will face in this is the disfigurement. Of course, the mandibular mass, leg mass will disfigure the child, and other symptoms that might appear for the child's loss of appetite, difficulty swallowing, constipation. Also, discussing other modalities of treatment with no curative intent. We give radiation for pain control, chemotherapy for pain control, and discussing end-of-life issues with a primary team or the palliative team. This is very important because it depends how your relation with the family. At first, if they are referred, it's better to be discussed by the primary team. The best scenario really is that the primary team and palliative team to sit together with the family and talk to them. But if it is a very new referral, it's better that the primary team. Sometimes when the patients are referred earlier for us, we can discuss the end-of-life issues, the DNR labeling our code with the family. And who should assume the primary care for the patient? This is very important also because sometimes the family, they are reluctant to go to the palliative care. So it's usually a joint care for the patient. I'm sorry for the slides. I don't know why they are not. Let's مش slide show يطلعوا.
Full screen.
Okay. Now, why these patients are referred for palliative care? What are the goals for palliative care? For patients with active, progressive, far advanced disease, the goals of palliative care to provide relief from pain and other physical symptoms, to maximize the quality of life, to provide psychosocial and spiritual care, and to provide support to help the family during the patient's illness and end of life. Now, to establish a service, you need 3 main things. The administrative preparation, you have to prepare your administration for this service, and you have to know how to make a team building and then how to operate this team. Now, for the administrative preparation, how can we convince the administration to invest in pediatric palliative care? Of course, because also the income from palliative care is really minimal in contrast to the bone marrow transplant or leukemia. نعم.
شير فول سكرين على الكاب سلايدز.
مش واضحة؟
لا واضحين بس شيرنج ذا فول سكرين كيف الكاب داون تتحركوا والسلايدات مش عم بتحركوا وقفوا على سلايدز تشالنجز.
هاي طالعة السلايد عندكم administrative preparation.
السلايدات يتحركوا كونتينيو يعني. شير سكرين. عملتي شير سكرين؟
عملت شير سكرين والله. يعني رجعت أسكرها وأرد أعمل كمان مرة.
لا أنت هلا ممكن تعمل دايركتلي شير للسكرين داون ذا سكرين فيه ممكن شيرنج.
وتختاري سكرين ما تختاري سلايد.
شيرنج ذا سكرين تختاري السكرين مش السلايدز. في الأخضر هذا السهم الأخضر شير سكرين.
ما أنا هي على الأخضر والله.
أوكي نعمل فول سكرين على الكاب هذا اللي هي.
أنا عم ممكن أعمل ستوب شير وأرد أرجع أعمل شير سكرين another time.
No, we don't have much time يعني لازم ناخذ يلا.
أوكي.
أوكي دكتورة أنور.
Okay. هلا على administrative preparation, you can convince the administration by more resources available for patients. We can treat more patients because the money that you will spend on a patient who is survival is very minimal. You can spend it on a patient who.
بس دكتورة أنور أنت
ما بتحركوا.
ما تعمل الشير وقفة و continue the same slides as you presented يعني before.
هيك كويس؟
تمام يلا continue.
هنحكي عن الادمنستريشن انه you can resources will be more available for other patients, decreased cost of symptomatic management provided to terminally ill patients, and برضه relief suffering for the family, which is very important, and for the child also. For the team building, you have to identify a key stakeholder. Sometimes you need one person or two persons that will build your team, either a doctor and a nurse, and also identify areas of alignment for palliative care. Conduct needs assessment, institutional leaders, physicians, other members of healthcare team, bereaved families, they might all help in building the team. Identify necessary program components to meet team. Identify clinical model to fit these teams. Consider location of care. Consider on-call coverage. Consider clinical lead role either by a physician or a nurse. Identify champions for models. Now, for the operation, to operate, you have barriers, either general or community-based or hospital-based. The general barriers are lack of consistent definition of palliative care relevant to all cultures. It's different from one concept of one culture to other, and the emotional issue, defiance of the natural order when a child dies, provider sense of failure when a child dies, immeasurable parental distress at loss of a child، لأنه ما حدا رح يعرف الشعور إلا اللي مجربه. And the prognostic uncertainty, which is مرات بيصير في differences. إيش الprognosis، قديش الsurvival، قديش الهاي. It might also confuse the family and confuse the team. Poor reimbursement for time, lack of universal healthcare coverage for children, fear of research in this population, and no palliative care network available for everybody. The community-based is a geographic diversity when the people who are living in the rural area, they might be deprived of the services of the palliative care, lack of reimbursement for critical services in the home, the psychosocial services, لأنه في services لازم تقدم مش الفيزيشن ولا النيرس can provide it. And the hospice limitations, when we say less than 6 months of life expectancy, lack of experienced pediatric clinicians, low daily reimbursement, and not offered if other nursing services already involve the child. يعني خصوصا إن لما نحكي عن الhospice care, usually it's a private sector, it's not a governmental sector. Also, we have ethical dilemmas with life-sustaining medical care, such as CPR, mechanical ventilation, that keep a person alive without necessarily reversing the underlying life-threatening conditions, versus palliative care and no CPR. Some people will come, and it's not ethical to do this, ethical or not ethical, but we have a fatwa إحنا من دائرة الإفتاء وفي consensus بكل الدنيا إنه it's really ethical to put a patient CPR if the life expectancy is not short, is very short, is if we all what the medical care that we are providing will not provide a healthy and the quality of life for this patient. Also, parents asking for treatment recommended by Google. I think everybody is now facing this problem because the parents will look for other solutions and other treatment for their child. Involving patients with trial therapies given on compassionate basis, given frequently in low-level evidence. This is a real problem that might face centers everywhere, that when you give a compassionate on trial treatment, the family might think that this will solve the problem and might cure their child. And also other families will ask to be put on this trial, even if they are the diagnosis is different and they may not benefit from this drug. Kshcc, for this, Kshcc has an ethical committee and research office that will help in such dilemmas. And for the hospital, these patients, when they require emergency visits, their stay might be extended and care be intensive. And the caregiver team usually, especially at Kshcc, the turnover is high for the physicians, the residents, and the nurses, those who are on the first encounter of these patients, so they are less familiar with how to deal with these patients, a varying level of experience, frequent changes, and different values. And as you can see, the background for this is the pediatric palliative care provision around the world, a systematic review. This is a global map. You can see our region. They are at level 2, maybe Kshcc at level 3, but still we are lagging behind the world. And the most important thing in the whole thing is the integration and the quality of care. And this is what we can always argue about, is the quality of care, quality of life, and the institutional-based level of integration. Education is vital for everybody and for all the newcomers, and updating your team about what is always new. I'll talk a little about the Kshcc model. Palliative care started in 2003. The aim was to minimize suffering of sick children even when cure is not achievable. Team component of oncologist, myself and Dr. Iman, she is a part-timer, she's a transplanter, one nurse coordinator, and the home care team. The program mission is to improve the quality of life of terminally ill children and their families, advance the field of palliative medicine to parallel those in oncology care, help to create comprehensive cancer care where palliative care along with anti-cancer therapy is involved in patient care from diagnosis onward. The services that we provide inpatient services, outpatient services, and home care, and phone service also. And all about the multidisciplinary care, the physician, the psychosocial, spiritual, and the social care. These are very important. So the multidisciplinary care is all about for the palliative care. And thank you very much.
Thank you, Dr. Anwar.
Thank you.
Next talk by Dr. Samir Yasser, consultant oncologist, and Head of Sarcoma and Melanoma Services in Kshcc, will talk about updates in the management of soft tissue sarcoma. تفضل دكتور يا سمير. دكتور سمير معنا؟ دكتور سمير خلينا نموف على النكست اذا احنا اوكي نموف على النكست دكتور سمير معنا؟
Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone. I would like first of all to thank the organizers for this meeting and for inviting me here today. Really it's an honor for me to take this opportunity to address such a distinguished audience. Let me first introduce myself. I am Samir Yasser. I'm a consultant medical oncologist at King Hussein Cancer Center and the head of sarcoma service. During the coming 15 minutes, I will be talking to you about the clinical updates in the management of soft tissue sarcoma. Sarcoma is a heterogeneous group of diseases. It comprises about 1% of adult cancers and less than 12% of pediatric cancers. And it is really a heterogeneous group of diseases. The most common subtype of soft tissue sarcoma is leiomyosarcoma, followed by liposarcoma. In the past, we used to say that liposarcoma is the commonest. Nowadays, it's leo, followed by lipo, and followed by GEST. And in this group of patients, there was a tremendous effort to improve the outcomes of soft tissue sarcomas. It has been used in the past several chemotherapy protocols to improve the outcomes of metastatic soft tissue sarcoma. And in this recent meta-analysis, different chemotherapy protocols were tested in the face of single-agent doxorubicin, and unfortunately, neither combination of chemotherapy was better than single-agent doxorubicin, and hence the standard of care became using single-agent doxorubicin for the management of advanced soft tissue sarcoma. The same applies to the adjuvant setting, and here the meta-analysis seeing whether the addition of chemotherapy to patients of resected soft tissue sarcoma, and the results were really marginal and less than the absolute survival benefit was less than 5%. The NCCN and ESMO guideline utilizes the adjuvant chemotherapy in a group of adult soft tissue sarcoma, where patients having a high-grade and large tumor, and especially in the extremity, those subgroup of patients may benefit from the adjuvant treatment. It is not the routine practice to give adjuvant chemotherapy for resected soft tissue sarcoma. This really created a gap and unmet need to fill that gap, so that the effort were really geared toward the subclassification of soft tissue sarcomas. And here is one of the famous subclassifications, where they use the NGS and genetic analysis to subgroup soft tissue sarcomas. For example, the well-differentiated and de-differentiated liposarcomas are now subclassified whether they express MDM2 or CDK4 or not. The MPNST or B-comas, whether they have the NF1 or TSG loss or not. The desmoid, whether they have the ABC or not. The leiomyosarcoma and undifferentiated pleomorphic sarcomas. These group of patients, they have a complex genomics, and nowadays we're using a tumor mutation burden in this group of patients to test the burden of complex genomic in this group of patients. And from that, there was a trend to dichotomize therapy for advanced soft tissue sarcoma into two groups. Whether there is a recurrent specific genetic mutation or signature for that disease or not. And based on that, there is a new way of treating advanced soft tissue sarcoma, which is a histotype-driven therapy. For example, a well-differentiated and de-differentiated liposarcoma that expresses the MDM2 and CDK4. Nowadays, there is an ongoing trials and promising results about using the palbociclib. For example, the alveolar soft part sarcoma, these are tumors that are sensitive to tyrosine kinase inhibitors. Based on that, we have two groups that has a specific sensitivity to a specific histotype sensitive to a specific treatment, or a general group of soft tissue sarcomas that are not peculiarly sensitive to any specific therapy. So that nowadays we're dichotomizing patients into a sensitive specific therapy or a general group. Whether this approach is really resulted in improvement in survival or not, let's see the result of a large phase 3 trial that was ran in Europe, looking into histotype tailored chemotherapy or a standard approach chemotherapy, which is the ifosfamide and doxorubicin, for a group of high-risk soft tissue sarcoma. And unfortunately, the approach using a histotype-tailored chemotherapy was not superior to the standard approach, which is using blindly chemotherapy for all types of sarcoma. So that the approach of using a histotype-specific treatment is not really the best way to treat advanced soft tissue sarcoma. Nowadays, we see a growing scientific body of evidence in a different subgroup of sarcomas, and if you pay an attention for the three lists of sarcomas, by the way, we have now أكثر من 77 subtype of sarcomas. 22 subtypes in bone sarcomas and 55 subtype of soft tissue sarcoma. And given the diversity of soft tissue sarcomas, عم بتشوفوا إنه The green light is the green color is the phase 3 trials, the blue one is the phase 2 trial. عم نشوف بس small group of soft tissue sarcomas هم اللي فيهم clinical trial, and there is a large subgroup ما فيهم clinical trial. هدول اللي ما فيهم clinical trial عم حاليا they are classifying them اللي هم بسموهم هلا ultra rare soft tissue sarcomas, وهدول اللي هم مسميهم rare soft tissue sarcomas, وهدول الحقيقة اللي هم فيهم هلا more advances in the management. هلا أنا I will take you fastly to show you the advances in the recent 3 years. شو صار على السوفت تيشو sarcoma and how we are going to manage soft tissue sarcomas. أنا راح أذكر 5 fields اللي كان فيهم improvement. أول field اللي هو multi targeted tyrosine kinase inhibitor and vascular endothelial growth factor inhibitors. أقدم دراسة اللي هي the oldest one is the Palliative trial, and this tyrosine kinase inhibitor, which is the pazopanib, was tested in a group of advanced soft tissue sarcomas that received less than 4 prior systemic therapy, and pazopanib resulted in an improvement in progression-free survival and trend toward median overall survival. And based on that trial, FDA approved pazopanib as a second line or beyond therapeutic agent for advanced soft tissue sarcoma. It's not only the pazopanib that's down there in the market. We have now several molecules like anlotinib, axitinib, sideranib, and regorafenib, which are active substances targeting different aspects of VEGF and KIT and RET, RAF, FLT, and FGFR. The most promising molecule is the regorafenib, and here from the phase 2 basket trial, where a group of bone sarcomas were given regorafenib as a second line, and you can see the improvement in progression-free survival and overall survival in osteosarcoma. In osteosarcoma, we have now an effective molecule that can be used as a second line, which is the regorafenib. Does this apply to soft tissue sarcoma? The answer is yes. In the REGOSARC trial, we have 4 parallel lines or arms that has been used to test the efficacy of regorafenib in this group of patients. We have lipo and leo. This is what we call L sarcomas, and the advanced synovial sarcoma and the other subtypes of sarcoma. In the REGOSARC trial, regorafenib as a second line did show an improvement in progression-free survival and overall survival, and in a subgroup of patients looking whether regorafenib is an active substance in patients who received chemotherapy and pazopanib, the answer is yes. Regorafenib did show an improvement in progression-free survival and overall survival in the group of patients receiving pazopanib. So that هذا واحد من lines اللي we can say that it's now it might be a standard of care second or third line therapy in advanced soft tissue sarcoma. What about anlotinib? Anlotinib was tested against dacarbazine as in the second line setting, and it conferred a progression-free survival benefit in synovial sarcoma and leiomyosarcoma. And amazingly, if you pay an attention to alveolar soft part sarcoma, هذا الديزيز احنا كنا زمان نحكي this is an indolent disease. It has a tendency to metastasize to the brain, lung and lymph nodes. حتى بعد الميتاسيسز they live years مع الميتاسيسز. Alveolar soft part sarcoma actually is sensitive to sunitinib, and here you can see the clear separation of progression-free survival curves in favor of anlotinib. So that this is again another molecule that nicely showed a good response in alveolar soft part sarcoma. هلا هذا كان اول ارم كان في امبروفمنت اللي هي تيروسين كاينيز انهبيتورز اند فاسكولار اندوثيليال جروث فاكتور. The second part او the second field اللي كان فيه improvement وحقيقة this TRK inhibitor it will change the face of sarcoma. As we know, the neutrophic receptor tyrosine kinases, whether anti-RK1, 2 or 3, هذا البروتين is specifically limited to the nervous system. بس لما بصير في chromosomal fusion مع other partner بينتج an active tyrosine kinase which activate a downstream signaling pathway MAPK or PI3K pathway, and hence the tumor occurs. The anti-RK fusion rearrangement is not peculiar to soft tissue sarcoma. We can see it in a subgroup of solid tumors, but most commonly soft tissue sarcoma, infantile fibrosarcoma, and thyroid, melanoma, lung cancer, we can see anti-RK. The percentage of anti-RK fusion in sarcoma is 1 to 2%. And here you can see the results of lorlatinib in the group of patients with soft tissue sarcoma and infantile fibrosarcoma. The overall response rate really reached 70%, and the duration of response 30 months. الحكي ما كنا نشوفه with chemotherapy or tyrosine kinase inhibitor. So that based on this trial, FDA now approved lorlatinib, larotrectinib and entrectinib in a group of advanced soft tissue sarcoma harboring anti-RK fusion gene. Unfortunately, زي tyrosine kinase inhibitors, entrectinib and larotrectinib as a first generation TRK inhibitors, down the road راح يصير في resistance. The most common explanatory pathway for the resistance is the development of solvent front mutation or gatekeeper mutation. من هذا الميوتيشن nowadays we have a second generation like repotrectinib and ciltrectinib, and in the group of patients progressing on larotrectinib, هون ciltrectinib in soft tissue sarcomas conferred around 45% overall response rate, and that was durable. Nowadays we have repotrectinib and talitrectinib. These are active molecules as second line after larotrectinib or entrectinib. فعشان هيك المرضى اللي عندهم هم 1 to 2%, I really encourage you to test for anti-RK. We have now larotrectinib and entrectinib. Repotrectinib showed an overall response rate of around 40% with low incidence of adverse event, and the response is really durable. And the third arm of improvement in the treatment of soft tissue sarcoma is the development of EZH2 inhibitor. This is an enzyme responsible for histone methylation. And we see the loss of INI1 and SMART-B1 in a group of soft tissue sarcoma, notably in epithelioid sarcoma. Really, their response to tazemetostat, which is an EZH2 inhibitor, it showed an overall 2 weeks a durable response. Now, the third.
يعطيك العافية دكتور سمير، الوقت خلص.
Now it's my honor to present Dr. Riyad Abdel-Jalil, a consultant of he's a consultant of thoracic surgery, the head of the thoracic surgery unit in KHCC. He will illustrate the management of small lung lesions. Please, Dr. Riyad.
السلام عليكم، يعطيكم العافية جميعا ويسعد مساكم. يعني جمع جميل إن شاء الله، فعله مسير رائعة. First of all, I would like to thank the organizing committee for inviting me to join this very distinguished and important conference in our Holy Land. Thank you for the organizing committee. Thank you, Dr. Mazen, and my dear friend, Dr. Abdul Karim al-Barqawi. Today my talk is about a very important subject. It faces all of the doctors, even the GPs, in any subspecialty, because you will see one of your relative or one of your patients come to you and say, I have X-ray, I have CT scan, and I see a lung nodule. What should I do? Should I think about lung cancer? Should I just ignore it? I don't have any symptoms. What to do? So I will try in the next few minutes to stress on these nodules, how to manage it, when to ignore it, when to closely follow it up, when to raise the suspicion of being cancer and start action immediately. So how we define the pulmonary nodules? They are well or poorly circumscribed, approximately rounded structures that appear on imaging as focal opacity, and by traditional definition, now we have extended definition, it's less than 3 centimeters in diameter and surrounded by aerated lung. It may be single or multiple. There may be associated subabnormality that raises the incidence or the suspicion for being a cancer. Now the definition is a little bit extended to include the peripheral nodule, the nodules on the visceral pleura, as well as with this time we are extended use of CT scans, the high resolution CT scans. Sometimes we can see 2 millimeters nodule. What to do with these nodules? And as a rule in medicine, we should look at the big picture. We should look at the nodule, we should look at the patient, we should stratify patient in high-risk patients, low-risk patients for getting cancer, and then we think about what to do with this nodule. So how can we see these nodules? Sometimes we just do a scan for like abdominal pain, for shoulder pain, and then we see this nodule. Sometimes we detect it during doing mammogram for ladies to detect breast cancer, then they see a lung nodule and they do imaging. Sometimes we do it as a lung screening program. So these patients are high risk for getting cancer, and we see these lung nodules, what to do with these lung nodules. And as I said before, we should look at the nodule, and then we look at the patient. If he's low risk, what to do? If he's high risk, what to do? So either incidental findings of these nodules, and these patients may be low-risk patients or high-risk patients for getting lung cancer, or in lung cancer screening, and we usually involve patients above 50 who smokes two packs a year, like 1 pack for 20 years, or 2 packs for 10 years, or who quit within the last 15 years, and then we include them in the lung screening program to detect the small nodules, and then what to do with this nodule if we see it. At Kshcc, we just started last month in the program of lung screening. We almost now recruited like 35 patients, and we look at these nodules. It's a 3-year project, and we will include 1,000 patients. It's important. It will save lives, because if you detect lung cancer when it's early stage, stage 1A, the cure rate will be more than 92%, and the cost will be less than $10,000. While if you detect the lung cancer in stage 4, and you need to give them targeted therapy or immune therapy, then the cure rate at best will be 20%. With chemotherapy, it's 0%. And the cost with targeted therapy and immune therapy may exceed $250,000 just for one patient. So look at the cost and the cure rate. So lung screening program will save lives. The other thing, what to do with lung nodules in oncology patients. If you have cancer patient, you resected his tumor, and then you do follow-up scans and you see this lung nodule, what should you do? So as I said, we should look at the nodule and we should look at the patient. So we should stratify the patients into low risk and high risk patients. Whose patients are at low risk of getting cancer, lung cancer? Usually the young. Usually the patients in his 20 or 30, usually his risk of getting cancer is low. If he is not smoker or lightly smoking, if there is no prior cancer, if the nodule is small, And usually you talk about less than 6 millimeters nodules. Usually it's a very low risk of getting cancer. So remember this number, 6 millimeters nodules. And if it's non-upper lobe, so if you see a lung nodule in the lower lobes, usually it's less suspicious than the upper lobe tumors and the upper lobe nodules. Whose patients is at high risk of getting cancer, lung cancer, usually the older, in 60s and 70s, usually who smokes a lot. And smoking is a very predisposing factor for getting cancer. In lung cancer patients, 90% of the patients are smokers and 10% are non-smokers. So smoking is a very high risk factor or predisposing factors to get cancer. If you have prior cancers, if you have a large nodules, usually 15 millimeters and 4, but 8 millimeters and 4, you should suspect or raise the suspicion of this nodules to be cancer. If you have upper lobe, if you have speculated margins, irregular borders, as I said before, if you have rounded nodules, then the suspicion is a little bit little. But if you have a speculated or multilobulated nodules, then the risk is higher. So these are some form of nodules. If you look at the picture on the left side, it's triangular. Usually triangular nodules are less suspicious because sometimes it's a focal atelectasis or a focal infection. If you have an elongated nodules in the fissure, these are the least suspicious nodules because it may be calcification, it may be like the anthracosis or a calcified lymph nodes. If you have a rounded or semi-rounded or speculated nodules like the one on the right-hand side, you should raise the suspicious for this nodule to be cancer. What about the GGO? GGO is a glandulous opacity. It's just an opacity. It's not a solid nodule. Sometimes you have subsolid nodules or semi-solid nodules. You have a small solid part surrounded by this haziness, the GGO. These are less suspicious than the solid nodules. If you have GGO that is transformed into semi-solid or solid nodules, then the suspicion is very high of this nodule to be a cancer cell. This again, this is on the right side, on the left side hand, this is GGO transformed into a solid part. So in this case, you should intervene either with non-invasive measures as PET-CT scan, or you should take biopsy to rule out malignancy. This scheme is a little bit complicated, but we can simplify it as the follow. So if you have a small nodule, less than 8 millimeter, or the patient is like very advanced disease, or he is like unfit to do anything, then you just discharge him and don't follow him. If there's any previous imaging, then you look at it. If there's no increase in the size of this tumor, then you should just continue follow up or ignore it. If there's no prior images and the nodule is less than 8 millimeter, then we will go to the next scheme. I'll talk about it in a few minutes. If it's more than 8 millimeter, then you stratify the risk of the patients. If he's low risk, then you go to the scheme. I'll talk about it now. If he's high risk, then either you do close follow-up or you do PET-CT scan and then go into surgical biopsy or invasive biopsy. I'll talk about the types of the biopsies. So if you have more than 8 millimeters nodule in a patient who's high risk of getting cancer, then you should intervene and do invasive procedures to at least to diagnose this patient and to make sure that he doesn't have a cancer. So as I said before, there are many guidelines put to manage these nodules. The most important and the most famous are the Fleischner, the American College of Chest Physicians, the British Thoracic Society, and the Lung CT Screening Reporting and Data System. If you have the nodule less than 6 millimeter in a low-risk patients, you don't even have to follow it up. If you have it in a high-risk patient who's a smoker, older, or in the upper lobe nodule, then you do annual follow-up. If it's between 6 and 8 millimeters, so it's at intermediate risk of getting of being a cancer cell, then you either you do close follow-up or you do it like in 6 months to 1 year. Okay. If you have more than 8 millimeter in a high-risk patient, usually either you do close follow-up in 3 months, or you just start investigating and do PET-CT scan, and you may need to do a biopsy. The lung grafts, it's like the BI-RADS in the breast. The lung grafts is important for the radiologist. If you have radiologists here, it's important to adopt this or utilize this, this scheme and look at the nodules and stratify them from 0 to 4x and 5. If it's less than 6 millimeters, if less than 6 meters, it's LRADS 2. If it's between 6 and 8 millimeters, LRADS 3. If it's between more than 8 millimeters to 15 millimeters, it's 4A. If you have more than 15 millimeters nodules, then it's 4B. And if you have another pathology, like if you have the lung nodules and mediastinal lymphadenopathy, or you have pleural nodules, then your suspicious will be even much higher. So how we translate this LRADS? If you have LRADS 3, then the probability of getting cancer is less than 4%. If you have LRADS 4A, then the chance of getting cancer is 15%. If you have 4B, then the chance of cancer is almost 36%. While if you have 4X, if you have lung nodule, and you have mediastinal lymphadenopathy, or you have liver nodule, or you have another sign of cancer, then the chance of this, of being malignancy, is approximately 80%. So you have now this lung nodules, it's very suspicious. How can I biopsy it? We have 3 ways of biopsy a lung nodule. Either we do it with image guidance, we utilize the CT scan or the ultrasound, localize the nodule, and then put a true cut needle. And usually we use this in the peripheral nodules, the larger nodules, and the benefit of true cut biopsy that you get a good tissue, and then you can do even more testing for genetic and PDL mutations. The other one is to do endoscopic biopsies, either with a bronchoscopy or with EGD. With EGD, you can go into the esophagus, you can see the mediastinal structure, and then if the mass is very central, you can get the biopsy with FNA. A bronchoscopy, you can use this bronchoscopy for two purposes. You can see if there's any endoluminal tumor, and then you can directly target this tumor and take a biopsy from it. If there is the tumor is surrounding the airway structure, then you can utilize the ultrasound and use something we call it endobronchial ultrasound guided biopsy. And then you see it with the ultrasound, and then you direct your needle into it, and then you take FNA, like we see there on the right side hand. If we can't do the biopsy with either endoscopy or CT guided, then we go to the surgical biopsy. What makes surgical biopsy nowadays easier is the utilization of the thoracoscopic surgery. Thoracoscopic surgery, when it was invented in 1990s, it was 3 ports. You put the trocars, and then you put your instruments through these 3 ports. With time, and 2012, we started to do the single port. We just eliminated the 2 ports, and we just do all this surgery with only 1 port. In King Hussein Cancer Center, we started to do the single port since 2016. We did almost 400 surgeries with the utilization of single port, and soon next month we will start doing the robotic surgery for the lung surgery for the first time in Jordan. So with this more invasive technique, we can take a biopsy from the lung nodules for diagnostic purposes. And if the nodule is very small, we can use some tools to localize these nodules. We can just, with the CT-guided injection of iodine dye, we can just localize it, and then for do the resection, we can put needle, we can put coils, we can put wires. So in VATS, we can just see it. So solitary pulmonary nodules are increasingly detected with the widespread of the CT scans. We should stratify our patients into low-risk patients, and then we can do either long-term follow-up or just ignore it. We can, in intermediate risk patients, we can just do close follow-up, and in the high-risk patients, we can intervene either with invasive procedures like surgery or CT-guided biopsy, or just with PET-CT scan to see if there's malignant or non-malignant. And as I said before, we can use three approaches to diagnose the lung biopsy, either with CT-guided, with endoscopy, or with surgery. And by this, I would thank you for your patience, and thank you very much.
Next speaker, Dr. Abdelrazak Abu Sitte. Dr. Abdelrazak, a consultant hematologist in UK, and he is a full-time consultant at the Prince Alexandra Hospital in Harlow. He is a fellow of the Royal College of Pathologists and a member of the Royal College of the Physician. Welcome, Dr. Abdelrazak. His talk today is about how to avoid deep vein thrombosis, pulmonary embolism in oncology patients.
Assalamu alaikum. Thank you very much for inviting me to present this talk. In fact, I have been invited by Dr. Salah Lubhaisi, who is sadly not with us today, and specifically advised me to prevent on preoperative management of anticoagulation. The talk is slightly different from the title on the agenda, but we will touch more on thrombosis in cancer patients. Okay, I will start with history, because learning some history can sometimes help to understand the future. It has been about 100 years now since anticoagulation was discovered, and it was in 1921 in the United States of America and Canada, when the farmers noticed their cattle died of unknown bleeding, and that took about 8 years to discover. The cause for that is the cattle fed on infected sweet clover was infected with fungus. Another few years where dicumarol, which is a vitamin K antagonist, was isolated. But instead of going to human use, it was used as rat poisoning in 1946. It hasn't been started in a human being at that stage, of course, because it was seen as a lethal drug until 1951, when an American surgeon who tried to suicide, and despite taking a large number of the dicumarol, he didn't die. And from that point, it was concluded that a chemical which didn't kill a rat, which killed a rat but didn't kill a human, must be good for a human. And President Eisenhower, he was reported to be one of the first human who took warfarin after he suffered heart attack. Now, this is very basics. I'm pretty certain you all know the anticoagulation, but what we use these days, we are using much less warfarin in anticoagulation, except a few circumstances which I will mention later, but these anticoagulants are still widely used. Unfractionated heparin, which or IV heparin, which we use in renal failure and in bleeding patients. Low molecular weight heparin, antithrombin inhibitors, and anti-TNA inhibitors like apixaban, rivaroxaban, and edoxaban. I'm sure, again, you know all of these. slides. Most commonly used anticoagulation, the DOACs with the direct oral anticoagulant. There is much less of warfarin use. It's still a good drug in certain circumstances. But the DOACs, worth knowing that they are not recommended in people with metallic heart valve, pregnancy, breastfeeding, and triple positive antiphospholipid syndrome. Indication, again, this is not new to you. We use them as primary thromboprophylaxis in people who are having surgery or in pregnant women. We use them as secondary thromboprophylaxis as people who develop VTE, needed a brief or indefinite period of anticoagulation. We use it in atrial fibrillation, and that's very, very important indication for anticoagulation. And of course, metallic heart valve. The reason why we don't use DOACs in metallic heart valve, because the risk of thrombosis. The thrombosis in metallic heart valve mainly depend on factor 9, while the direct oral anticoagulant, they rely on more clotting factors. So going to the cancer and thrombosis, I'm actually surprised to know that dying of PE or a VTE is the second leading cause of death in cancer patients. And it may precede the diagnosis of cancer. Therefore, patients who present with truly spontaneous PE or DVT should be actively investigated for the cause of the thrombosis by screening for cancer. 30% of patients who died of pancreatic cancer are found to have thrombosis in autopsy, and the percentage is higher in people who die of tumors in the body of tail of the pancreas. So knowing anticoagulation and knowing its implication in cancer patients by no means will improve the outcome of cancer patients. This maybe there's a slide missing. Okay, these are all general. I'm sure you all know of them. There has been a lot of initiative to identify the risk of thrombosis in cancer patients at the start to facilitate introduction of anticoagulation and managing its anticoagulation. And as you can see, age, like anything else, is a high risk factor. Body mass index, especially if it's greater than 35. Post-operative complications like wound infection, intubation, cardiac arrest, and sepsis, and local hospitalization, especially if it lasts more than a week. There are additional risk factors such as metastatic disease, ascites, hypoalbuminemia, platelet count. Most of the surgery patients, they get reactive thrombocytosis, which is in itself is a significant high risk for thrombosis, and any duration of operation lasting more than 2 hours. The list is exhaustive, but these are other risk factors like vascular stasis, for example, in lymphoma, compressing one of the large blood vessels, sepsis and disseminated intravascular coagulation, thrombocytosis and leukocytosis. You get post-operatively leukocytosis as a physiological response. It does increase the risk of thrombosis. Certain antineoplastic agents, certainly in hematology, thalidomide and lenalidomide, we consider them are highly thrombogenic drugs, and I'm sure the oncologists, they have their own version of thrombotic thrombogenic agents. Erythropoiesis stimulating agents, we have been using many erythropoietin lately in chemotherapy to reduce the risk of blood transfusion, and this is in itself is associated with higher dose of thrombosis. And not surprisingly, enduring central venous catheters use it for administration of chemotherapy. You may know this more than me, is now the calcium-dependent cystine protease has been found in malignant and fetal cells, but not in normally differentiated cells, and this may represent in the future a marker to predict which of your patient more likely to develop thrombosis. It has been noticed in acute promyelocytic leukemia, melanoma, and cancer of the colon, breast, lung, and kidney. Now, this is the more complex and challenging treatment, is how to do surgery in a patient who is anticoagulated. I think this is the topic which I have been asked to present. It's a challenge for the surgeon, a challenge for the anesthetist, and also a challenge to a hematologist. And these are the guidelines from the British Society of Hematology, and I'd like to attract your attention that most of the guidelines, policies for hemostasis and thrombosis, not relying on a good evidence-based practice, and it is more of local experience and local experience. So patient with active or recent cancer admitted to hospital, I'm sure you do this, should receive thromboprophylaxis throughout their admission unless contraindicated. Patient undergoing abdominal and pelvic surgery for cancer should be considered for extended thrombocytosis, and even outpatients who are fully mobile but they have cancer or thrombogenic cancer should be considered for extended anticoagulation as outpatient. One of the questions I always get asked from my colleagues, when should we stop anticoagulation if the platelet count is dropped? And the arbitrary cutoff value is usually 50. When we have a patient who is due to have surgery and anticoagulated for any reason, for example, atrial fibrillation or recent PE or high risk thrombophilic defect, it's unfortunately there is no selective anticoagulation. Somebody who is anticoagulated and come with GI bleed or come with ruptured abdominal aneurysm, there is no selective anticoagulation which can be done to...
2 minutes, doctor.
Sorry?
2 minute time.
Thank you, yes. So it has to be risk balanced, and patients who have high risk of thrombosis should be bridged with alternative anticoagulation, while if the patient they have low risk of thrombosis, if anticoagulation is stopped, they can proceed with surgery without stopping anticoagulation. Atrial fibrillation, as you know, is a very high risk, and especially if the CHA2DS2-VASc score is greater than 4. And the second paragraph is more important. If you have a cancer patient with atrial fibrillation who is anticoagulated, if you stop anticoagulation, the risk of thrombosis is 0.5% a day, and that is translated to about 15% if in 1 month. Prosthetic heart valves are a major problem because these days warfarin is used in this scenario, and managing their anticoagulation around time surgery is challenging. I will try within my time to present it in the last slide. For the sake of the time, I will skip this slide. And this is the bleeding risk when you have somebody who is on anticoagulation, needed surgical procedure. You need to assess the risk of bleeding due to the nature of surgery, their age, kidney function, and if they are taking concurrent medications. I'm not going to go through all of this list, but these are the list which is deemed to be high risk of bleeding from the surgical point of view. As you can see, the surgery, vascular surgery, prostate surgery, and any surgery, in fact, lasting more than 45 minutes. While these are list of surgeries which you could do generally without the need to interrupt anticoagulation, and usually each department, they should identify the list for low-risk bleedings. This is a Has-Bled score. It's a score which was developed to help the clinicians to decide if I operate on this patient, is he likely to bleed or not? And the highest point will point if you have to interrupt anticoagulation. This is a busy slide, which I probably put her in the first. With DOACs now, I'm sure they use it in Palestine. You don't need to bridge, and managing anticoagulation is much easier with the DOACs, and you just have to risk stratify your patient from the surgical point of view, minimum, low, medium, or risk, and all what you need to interrupt anticoagulation for maximum 4 days. And by doing that, you reduce the risk of bleeding. Warfarin is still a problematic, and when you want to operate on somebody on warfarin, you would like to be more specific in assessing the risk of bleeding, and if the risk is bleeding, you need to do something called bridging, stopping warfarin and start low molecular weight heparin. This is a quick slide just to show you if you have a patient who's having surgery and having apixaban or rivaroxaban, when to stop 2 days before surgery, day of the surgery, and restart the day after the surgery if they have high bleeding risk, while if they have low bleeding risk, you start 1 day before surgery. Bridging, quickly, this is nearly the end, is how to switch warfarin and to restart heparin. Thank you very much.
يعطيك العافية.
Thank you, Dr. Abdelrazak. Our next talk is about an important topic, cancer of the rectum, which presents challenges to both surgeons and oncologists, and also presents challenges to patients themselves in terms of cure and quality of life. Our next speaker is Professor Tariq Al-Jabiri from King Abdullah University Hospital. He's a professor of surgery and colorectal surgery at King Abdullah University Hospital and the Faculty of Medicine of Jordan University of Science and Technology. Let's watch this pre-recorded talk.
Mr. Chairman, dear colleagues, I want to thank the organizing committee for the opportunity to speak in front of this honorable meeting held on the beloved land of Palestine. I want to talk about some controversies in rectal cancer management. To this extent, the first area of controversy controversy is the rectum itself and accordingly of rectal tumors. There is a lack of a clear consensus on this, and since we know that the management of rectal and sigmoid cancer is different, this lack of consensus has led to significant differences in trial recruitment, management, and outcomes. The classical definition of rectal tumors are those tumors with their distal margin within 15 centimeters of the anal verge. However, we know that the length of the rectum varies according to the body habitus and gender. Specimen analysis have proved that the sigmoid takeoff defines the upper termination of the rectum, and this can be shown on MRI as the mesocolon elongates. So perhaps this is the best definition for the upper rectal border. Within the same context, most guidelines are telling us that the management of upper rectal tumors is different from those in the distal 2/3. Putting aside definitions using figures from the anal verge based on MRI or colonoscopy, we can say that the optimal definition of upper rectal tumors are those lying above the anterior peritoneal reflection. The other area of controversy is the best approach. After a long journey of rectal cancer surgery over the last 300 years, the beginning of this century witnessed a recommended treatment of locally advanced rectal cancer in the form of neoadjuvant chemoradiotherapy based on 5-FU or capecitabine, followed by total mesorectal excision, followed by adjuvant chemotherapy. However, this type of management was found to be associated with significant mortality and morbidity in the form of bladder and sexual dysfunction, bowel symptoms as described in the low anterior resection syndrome, problems related to stomas, leaks and wound complications, and toxicities from chemo and radiotherapy. This has called for a treatment modification. The development of high-resolution MRI over the past decade helped in more individualization of the treatment options based on the MRI criteria and the tumor location within the rectum. Different chemotherapies has been tried within the neoadjuvant chemoradiotherapy part of the treatment. Oxaliplatin and cetuximab were tried with no significant improvement in the endpoints. Vascular endothelial growth factor inhibitors were tried. There was some encouraging responses in regard to pathological complete response, but it was on the cost of increase in the surgical complications. Chemoradiotherapy was tested whether pre-operative or post-operative. The results were in favor of pre-operative chemoradiotherapy when it comes to local control without an effect on the overall survival. The radiotherapy dose modification was tested, increasing the dose up to 60 grades from the classical 54. Some advantages were reported, but on the cost of more toxicity. However, this might be an alternative for distal rectal tumors when the treatment option includes abdominoperineal resection. The long versus short radiotherapy courses were compared. No differences in the rates of of the classical endpoints, apart from the local control, where the long course was more effective in controlling the tumor locally and increasing the pathological complete response. But again, on the cost of an increase in acute toxicity. So the short course remains a reasonable choice if you are working in a center with a long waiting list. The timing of surgery after the neoadjuvant setting was tested. For the short course, it seems that the best timing is after 4 to 8 weeks. For the long course, you can extend your timing up to 12 weeks or even more. The more you wait, the more you will get complete pathological response. Omitting chemotherapy from the neoadjuvant setting using only radiation alone was tried, but the results were in favor of neoadjuvant chemoradiotherapy when it comes to local response and local control, but no benefit regarding the overall or free survival. Total neoadjuvant therapy was tested, which means giving both chemoradiotherapy and chemotherapy before surgery. This is increasingly adopted, but the optimal sequence, i.e. induction versus consolidation, needs more verification. It seems, however, that the upfront chemoradiotherapy followed by chemotherapy followed by total mesorectal excision carries the best results when it comes to pathological complete response and compliance, luckily without compromising the other endpoints. Accordingly, we started to see some deviations from the classical treatment, so we started to do local resection for T1 tumors. We started to omit the neoadjuvant treatment using surgery alone for early T3 middle third rectal tumors and upper third rectal tumors without risk factors for local recurrence. And accordingly, we started to see more complex algorithms that depends on the tumor location, the MRI findings, and the response to the neoadjuvant chemoradiotherapy. However, a lot of questions remain without answers, like what to do with T2 tumors, which are still hanging between local excision and surgery. Can we do more for organ preservation for low-lying tumors which need abdominal perineal resection? Can we expand the surgery alone for all low-risk T tumors? Can we expand on total neoadjuvant therapy for T4 tumors? Another area of controversy is organ preservation or what is called watch and wait policy. Since its introduction 18 years ago from Brazil, with the excellent initial results of low local recurrence and equivalent 5-year survival, further updation from the same team have shown that the results were not as brilliant and the local recurrence was significantly higher than previously reported. This has raised interests as well as concerns regarding this treatment policy. Since then, a plethora of results of different trials from all over the world came about regarding this type of management. Of course, we cannot go through all these, but I can summarize the current status for this by saying that it is a challenging clinical situation. It is observed more and more as we intensify chemoradiotherapy protocols, including total neoadjuvant therapy. Controversies remain about the definition of complete clinical response, the management of regrowths, and the effect on endpoints, including metastasis. Currently, there is no level 1 evidence to support watch and wait policy. For now, surgery should remain the standard treatment. However, you can perform this policy in the context of clinical trials as long as the patients are fully informed about the ramifications. What can we do to improve the application of this policy? Simply by picking up those responders to chemoradiotherapy. And this can be done by studying the tumors histopathologically, since we found that the type of response in the form of shrinkage rather than fragmentation is associated with more favorable response. Molecular testing and genetic testing of the tumor, as well as improving the imaging technologies like the radiomix, which are algorithms based on features extracted from imaging. This year, we received more than one publication in this regard. Another area is genetics and the targeted therapy. The more we are doing genetic testing for those tumors, the more we have found that there are subtypes of colorectal cancer, and colorectal cancer is a heterogeneous disease at the molecular level. So mutations, different types of mutations, microsatellite instability, and circulating tumor DNA are expected to be part of the standard care of those tumors. Actually, some of them are already part of the standard care. Now, what's the importance of this? We can use targeted monoclonal antibodies against specific types of rectal cancer according to the genetic defect. The classical example is what came out in the last ASCO meeting a couple of months ago and published in the New England Journal of Medicine, where a subgroup of rectal cancer harboring mismatch repair deficiency were highly sensitive and completely responding to monoclonal antibody anti-PD-1, and the drug is the dostarlimab. It's too early to celebrate. Longer follow-up is needed. However, these results brought about a lot of interest, not only at the medical level, but at the social media levels. Actually, some patients started to ask about this type of treatment, especially when their treatment plan includes abdominoperineal resection and permanent stones. At the moment, more than 34 ongoing studies are dealing with the same subject, not to mention trials dealing with other types of mutations and monoclonal antibodies. Another area of controversy is minimally invasive surgery, including both laparoscopy and robotic surgery. Again, a plethora of publications in this regard. I put the results of these in a chronological manner for both laparoscopy and robotic surgery.
1 minute.
Of course, because of time limitations, we cannot go through these, but I can put some summary about this by saying that when we compare laparoscopy versus open, we witnessed similar pathological endpoints, similar long-term survival outcomes. However, the non-inferiority of laparoscopy was not established compared to open, and the endpoints may not support laparoscopy as a routine standard of care. When it comes to robotic surgery, Again, no difference in recovery, oncological and post-operative outcomes. The cost is higher. There is controversy about the conversion rate and the operative time. Some encouraging reports came about indicating an improved recovery of the anorectal function. I have to emphasize here that what I have talked about is the oncological outcome of these procedures. People are doing these more and more, not because of the oncological outcome, but because of the other benefits of minimally invasive surgery, like the shorter hospital stay, less pain, etc. Another area of controversy is lateral lymph node dissection, basically for low rectal tumors. It is the standard of care in Japan, but not elsewhere. The last publications have shown that when the MRI is showing lateral lymph nodes more than 7 millimeters in diameter, those patients do benefit from lateral lymph node dissection, basically in decreasing the local recurrence rate. Of course, further validation and reproduction of the results. Lastly, how can we contribute to the management of patients with rectal cancer and to the literature in this regard? If you want to do so, you have to be part of the international collaborative initiatives and consortiums. The personal experience will not add much to the literature. There are many areas of controversy in rectal cancer management that I cannot go through because of time limitations. However, I end up by saying that in spite of what we have achieved so far, more than 30 to 40% of patients with rectal cancer will not survive the 5 years, and most of those who do so will live with a long list of morbidities. So I did not aim to increase the confusion about rectal cancer surgery, but rather to say that there is a long way to go. Thank you again.
The next speaker is Dr. Walid Dana, Consultant Medical Oncologist in Kshcc, and he will present a case report with the title of Plastic Plasma Cytoid Dendritic Cell Neoplasm, underwent chemotherapy and BMT.
Good afternoon. Do you see my slides?
دكتور وليد تفضل.
Yes, okay. Just a minute.
تفضل دكتور وليد.
Yes, okay. So good afternoon, everyone, and it's my pleasure to be here today. And thank you for inviting me to speak to you at your annual conference. I will present a case regarding plastic plasmacytoid dendritic cell neoplasm, underwent chemotherapy and bone marrow transplant. First of all, we certify that we have obtained all appropriate patient consent form, and patient has given his consent for his images and other clinical information to be present in this conference. First of all, I will talk about overview of plastic plasmacytoid dendritic cell neoplasm. It's a rare clinical aggressive difficult to diagnose type of hematological malignancies with a poor prognosis. Incidence is difficult to estimate due to lack of clear definition until 2008 WHO classification. It represents only 0.5% of all hematological cancers. An estimated 1,700 cases annual in the US and Europe. It's no clear racial predisposition. Male affected more than female with a ratio of 3:1. And epidemiological database underestimated the incidence of BBD-CN, giving the minority of patients presented without skin lesion. So most patients presented with cutaneous manifestation, and these cutaneous manifestation with skin involvement, with nodular, diffuse, bruise-like macules, and most patient, a minority of patients presented with peripheral blood involvement, bone marrow, lymph node, and visceral involvement. Need to be familiar with these type of malignancies, and the differential diagnosis with this type of malignancy is we need to exclude other like AML, leukemia cutis, non-Hodgkin lymphoma, ALL, CMML, MDS, and cutaneous lymphoma. Mean time between the onset of lesion and pathological diagnosis is 6.2 months. And this is the case I will present today. This is a 59-year-old male patient, ex-smoker. He has a history of gout, no family history of malignancies, presented with right arm small mass, red, not painful. He ignored this mass for a few months and sought medical advice at local medical center, then lost follow-up due to COVID pandemic. Then referred to Kshcc for possible skin malignancies in January 2021. Examination of the patient showed large, as you see, fungating mass at the right arm, around 10 by 10 centimeter. Also, you can see that this patient has left facial swelling or mass. And in the anterior wall, there is also a blackish mass in the anterior wall. So we got a biopsy from this mass, and the mass consistent with plastic plasmacytoid dendritic cell neoplasm. The tumor positive for CD45, CD43, CD5, CD4, and locally positive for S100. Also, it's negative for TDT, CD99, and other immunostains. Workup including also CT chest, abdomen, pelvis that showed no visceral metastasis or enlarged lymph node. Also, we did a bone marrow biopsy and showed normal bone marrow without involvement by leukemic cells or infiltration. Flow cytometry in the bone marrow showed negative for leukemia. Also, we did a CSF to rule out CNS involvement as these patients may have increased incidence for CNS disease. Brain CT scan and brain MRI. In the right side, you see large left hemiface mass invading the maxilla and paranasal area. Also, a patient has a thickening involving the right nasopharynx with multiple subcutaneous soft tissue lesion through the anterior chest wall, and all these suggestive of disease infiltration. And this also confirmed by PET CT scan. Patient offered treatment with chemotherapy as we don't have targeted what called TAGRAS. It's targeted against the 1, 2, 3. So we offered him with chemotherapy, but he refused initially and returned again with infection. Re-evaluation and examination showed same large fungated, but in this time was infected mass and his with large facial mass. And also patient developed anterior chest wall mass, left lower leg mass, and he underwent evaluation with a new bone marrow aspirate, and biopsy showed no involvement by disease. At the end, patient agreed to go for treatment. So he received palliative radiotherapy as 30 gray in fraction to the right arm, which completed on 13 of July 2021, and then he induced with high bar CVAD regimen. He started with 1B followed by 1A. Then we gave him cycle 2B in 19th of August 2021. He developed toxicity by cerebellar symptoms and acute kidney injury related to cytarabine. So we stopped chemotherapy, and patient started on follow-up. PET-CT scan during chemotherapy on 1st of September 2021 showed mildly hypermetabolic right arm cutaneous activity in favor of post-radiotherapy changes. And he has also increased bone marrow activity in favor of reactive bone marrow changes. Cycle 2A was given on 9th of September 2021 without intrathecal cytarabine. Then he received cycle 3A instead of 3B because of toxicity due to cytarabine. After 3A, patient underwent bone marrow transplant. And this is the slide showed after hyper CVAD regimen showed good response to treatment, and you see the face, the mass result, and the right arm also showed good improvement to treatment. After that, the patient underwent allogenic bone marrow transplant on 18th of November 2021. He received conditioning regimen with the flu TBI 8 days, and GVHD prophylaxis was cyclosporine and methotrexate. He underwent bone marrow transplant from fully matched brother with peripheral blood stem cell dose, nucleated cells 8.72 times 10 to the power of 8, CD3 17.5 times 10 to the power of 7. And the CD34, the dose was 7.9 to the power times 10 to the power of 6. At the day 14 after transplant, he has an engraftment, and evaluation done on day 30 by PET-CT scan showed complete remission. We did a chimerism and showed 97% donor cells. Follow-up chimerism at day 100 plus showed 99% donor cells. The patient remained on follow-up. He has excellent response, and he is doing well. And you can see the response to the treatment after radiotherapy, and this patient after day 100 plus after transplant, you see the mass is almost healed, leaving just a scar in his arm, and his facial feature almost back to normal. At the end, conclusion and recommendation, PBDCN is difficult to diagnose due to overlap with other hematological malignancies. Early diagnosis is important. Delay can mean disease progression. We need to improve understanding of the biology of PBDCN and increased awareness among clinicians and pathologists to improve diagnostic workup to these patients. So in general, diagnosis should be based on immunohistochemistry and flow cytometry. And these patients, they have a triad with CD4, CD56, and CD123. So current chemotherapy induction for this disease have a lack of durable response, low overall survival, and early mortality. ALL chemotherapy regimen has better response than AML chemotherapy regimen. FDA approved the TAGRAS regimen and should be considered in eligible patient with PBDCN. For adult patient, the allogenic bone marrow transplant in first remission, better than observation alone, this based on retrospective study. reported favorable outcome in adults who underwent allogenic bone marrow transplant. Most adult patients who receive no post-remission therapy relapse within 2 years. And this is the end. Thank you.
Thank you, Dr. Walid.
Our next speaker is Dr. Amjad Parvez, which is a distinguished laparoscopic and robotic colorectal surgeon at Hamad Medical Center in Qatar. Dr. Amjad has a long experience in the different centers in the UK and Europe, and he's also the director and founding member of the European Academy of Robotic Colorectal Surgery. Dr. Amjad will talk us through the modalities in the management of rectal cancer. Dr. Amjad, please.
Thank you very much. Are you able to hear me?
We hear you, we see you.
Okay, well, thank you very much for the very kind invitation. Thank you to my colleagues who are patiently waiting. I'm a colorectal surgeon who has interest in minimally invasive surgery, which these days is seen as laparoscopy and robotics. So I'll speak a bit about this and then touch what is available in terms of organ preservation. And I know one of the speakers have already spoken about it, so I won't go into detail for that. So I see if you can see my slide. Are you able to see the slides now?
We see the first slide, yes.
Okay, yeah, okay. So at the moment, I'm working at Hamad General Hospital in Doha, Qatar, with the colorectal department there, and I'm helping them with robotic program in particular, or laparoscopy in general. And we actually have one of our fellows who's actually from your part of the country, who has just joined us as well, and hopefully he would be well trained before he returns back to join you as a colleagues too. In addition to this, I work at this place a week a month, Shimbelemo Foundation in Lisbon, which is Portugal. This is a cancer institute, and I've been associated with them for the last 8 years, helping them develop a laparoscopic and robotic program. It is a fantastic place to work and to come, of course. And this is an open invitation, which is extended to all my colleagues sitting there listening to me. If they wish to come and visit Portugal, all they have to do is to drop a line and they're welcome to come. So how rectal cancer surgery has evolved in the last 3 or 4 decades. We know that the concept of total mesorectal excision introduced by Professor Bill Heel reduced the local failure rate from 30 to 40% down to single figures. This is now accepted as a gold standard, regardless of whichever way we do the operation. We also know that the introduction of stapling device increase the sphincter preservation rate. So less abdominoperineal excisions are done and surgeons are able to go lower and lower. A couple of decades ago, the group from Karolinska introduced the concept of a cylindrical assessment for abdominoperineal excision, claiming a better failure rate and better survival as well. And we know, at least for the last 2 decades, that laparoscopy have played a central role demonstrating improved short-term outcome, at least, with equivalent oncology outcome, and now increasingly robot science way as well in the treatment of cancer. I have a privilege of teaching and training people around the world, and this allows me to interact with different cultures and different places. In fact, I have visited your country, the other side of your country, when I was in Ramallah a few years ago, at one of the surgical meetings, on invitation of some of my colleagues, including, I think, Dr. Abu Hilal, who is a HPP surgeon based in Italy now. He invited me. So this is one such a patient which one of our guys that we've been going around training sent me and said, Prof, what do you think of this? This is our first laparoscopic abdominoperineal excision. And most of you would look at it and agree that from outside it looks okay, except that the stoma is probably more lateral, which the surgeon sitting in the audience would spot. but everything else looks outside. So I said to them, because it is done for cancer, can you send me the picture of specimen? Because then I'll be able to give you a true feedback. And when you look at the specimen, you would agree that this is not cancer surgery. You know, the whole idea is not to just take something out and do a bad cancer operation. So minimally invasive surgery remains a tool, not the religion. The religion for surgeon remains anatomy. This is a wonderful work which is produced by a friend and a colleague from the University of Ankara, Professor Kuzu, for our teaching material. These are cadaveric dissections done with the illustration showing pelvic anatomy and abdominal anatomy. And I think, I don't know how many are sitting listening to this, but this is the religion for us as surgeons. You know, anatomy remains, these are cadaveric dissections, the resource for teaching and training that are available free of cost. You know, you don't have to pay for this, and please spend time learning anatomy. Because once you would learn anatomy, laparoscopy and robotics become the tool for you to explore the anatomy and lead you to show better outcome. So, Homo sapiens anatomy hasn't changed for the last 250,000 years at least, and it's not going to change in a hurry. So if you learn anatomy, you will become a very good anatomical surgeon demonstrating excellent outcomes. The problem with laparoscopy. Okay, so let's talk about laparoscopy before I go to robotics. So problems are very obvious. You know, male patient, obese patient are problems, and then there is exposure in a male bony pelvis with a narrow space, which become a challenge. Radiotherapy add to the challenge, we know, and published data from Kshcc trial in England, where I work, showed 25% circumferential dissection margin rate positivity, and that was a problem adoption of laparoscopy at the beginning. This is color 2 data. This is data which is 10 years following color 1 study. Surgeons have become better at doing it, and even in those days, they showed the conversion rate was about 17% and 10% CRM positivity rate, both in laparoscopic and open group. Americans published this recently in JAMA, showing that laparoscopy specimens are slightly bad when you compare to open technique. But interestingly, if you look at rectal perforation rate in laparoscopic arm, this is nearly 16%, which is very high. And that shows that perhaps the laparoscopic skill was a problem rather than anything else. Australian Ellicott study demonstrating exactly the same. Now, at the same time, some people can do it very well. This is a Korean trial basically demonstrating mid to low rectal cancer post-chemotherapy. So difficult technical group, P3 and 0, laparoscopic versus open data, looking at 3-year disease-free survival. And they were able to demonstrate equivalent overall survival, similar local recurrence, and equivalent disease-free survival, with a conversion rate of less than 1%. So when we have data like this come from Far East, we tend, in the Western Hemisphere, Europe where I work, we tend to hide behind the fact that perhaps they have easy patients, they have slim patients, and they can do this better because they don't have a problem with obesity. But the truth really is they are high volume centers with dedicated colorectal unit doing large numbers, and that's why they This is our own data from Portsmouth where I work, standardized approach to laparoscopic surgery. When we looked at our rectal cancer data, nearly 300 PMEs done in our center, showing good overall survival as well as disease-free survival for each disease. And I had difficulty publishing data because everybody said you could do this very nicely, but it is not a generalizable technique. It's very difficult for other people to produce similar outcome. So I asked 3 of my fellows, just people like Ali perhaps, finished the training and went on independent practice, asked them to share their data. So look at the comparative data between 3 individuals and AP, which is me. Everything is very, very similar. So it is not only possible to produce these outcomes, it is also possible to reproduce by teaching others. And this has been the case for many years. These are videos from 2006 or 7, and we standardized this excision technique down to very, very minor details. I have never used sort of very fancy instruments because initially at the beginning, the big thing was that if you don't have fancy instrument, you can't do complex pelvic surgery. I have used monopolar diathermy hook with a very low current setting, but standardized anatomy and standardized operative technique in a way where you are able to see the same operative picture over and over again. Easy to do, easy to teach to your trainees as well. And this remains true, what I said, it is not so much what you are doing inside the patient, what you remove, nice intact TME specimen, intact vesicle, facial plane, and it should look consistently similar, rather boringly similar each time you do the same step of the operation. The problem with laparoscopy people often used to say is the difficulty is to go lower and staple. There has always been a technique around it. You can easily do it in section, take the specimen out from the bottom end and divide it proximally, and then do a coloanal hand-sew anastomosis. So this is not really the problem. The problem really is to identify and the specimen should look really nice, rounded, complete, mesorectal package with a tumor with a clear margin. That's the whole idea of doing. What about TATME? Now people are trying to get this from below. So far, some systematic reviews and personal small number series are published, and currently at least one RCT is being done to look at the outcomes in a comparative way. In some countries in Europe, this technique has been stopped because of abnormal lateral dissemination of local recurrence patterns seen within 1 year. I think in Norway and in some part of Holland, the figure is somewhere around 11% in 1 year. So when you look at European guidelines for doing transanal TME, it is for BMI of 30 and above, post-chemotherapy, male pelvis, big prostate on MR, and low rectal cancer. These are rare cases. And that's why when people sort of incorporate guidelines in the practice, they would always fail to show better outcomes. Two such papers, this is the Cleveland Clinic data showing TME quality was deemed intact, satisfactory, complete. CRM rate was 7.8%, and they look at it as transanal TME. And then the rest of the things were exactly the same. This is Lacey's data from Barcelona, 186 patients consecutively, looking at things like dissection margin, rate even, and they look at complete mesorectal excision margin, CRM rate, very, very similar to laparoscopy. Similar things are shown by this California group. So in conclusion for transanal TME, level 1 evidence is still lacking. Operative technique needs to be standardized, and they are working on trying to design a curriculum looking at long-term functional and oncology too. So what is robotics in this? It does give advantage in aerospace, but it needs to be done, taught, and performed anatomically. That's the key. Robot has evolved in the last few years, starting from turn of the century down to most recent level, for what they call generation 4 robotics, which we have in Doha as well as in Lisbon. Some meta-analysis showing less conversion and better urogenital function in robotic arm when comparing lap with robot. This is another updated study looking at meta-analysis of 17 studies showing reduced conversion urogenital function at the cost of increased operative time. This is ROLA trial, which is published. This is perhaps, until recently was the only trial. The Chinese have published another one recently, but they look at short-term outcome, showed no difference between both groups. This is data from various institutions that I have been associated with. We looked at urogenital function. We look at high-risk patients. We also looked at obese patients, and we were able to demonstrate that robot was superior in all these high-risk patients when you compared live with live. This has been looked at by other authors, validating our studies too. So it's more or less look like this when you are, it's really truly not a robot, it's a master-slave concept. So it only performs the task what the surgeon asks them to do. You sit on the console, attach this patient, and then basically you're using these arms sitting remotely, but you have a 3D view and you have a 10-time magnification. So it allows you to see things very, very precisely. And it's apparent very, very obviously when you do anatomical operation using this tool, it's the anatomy that dictates the technique, not just the tool. You know, you can do the similar operation using a diathermy hook. Obviously, the camera would be creator dependent, and also there would be an element of what you call straight sticks restriction. So the arms can angulate at the tip, and you can use the scissors just like a cobra head and get it in narrow spaces. It is applied in advanced tumor. This is one of the cases in Doha, a lady with rectal cancer, increasing interiorly involved uterus. I'll fast forward this. I told you late in the day, and I do apologize. Artery and vein are done. This is the start of the TME posteriorly. You go into this, what you call total mesorectal excision plane or avascular plane. Some people refer to this as a holy plane. But the idea really is that you circumnavigate the specimen until you get to the bottom of it. And then anteriorly, mobilize uterus, take the round ligament and uterine ligament within the clips. And then you move it forward by taking uterine arteries in continuity, which you will see just now. These are the uterine vessels being taken in continuity. You can use a clipping device by the robotic arm, or you can ask an experienced assistant if you have a senior fellow, like, you know, if a sensible fellow like Ali sitting on the bedside, they could do this for you. And once you've taken this, you go past this, ask the swab to be introduced within the vagina, and you can divide the back wall just like that on vision. Now you've gone past the tumor, of course, then you go a bit more straightish until you are on the pelvic floor and the TME is complete. Then you can staple this very, very safely and do the anastomosis and close the vaginal defect. So it does confer advantage in subset of patients with difficult challenges. Same thing can be seen in male patients. These are anterior dissections. I'm sure you've seen all of these, and that would be of little interest to you, but the idea really is to demonstrate the versatility of this instrument in a narrow male pelvis. You can obviously use the tool to occlude the bioabdomen, do the distal washout, look at it endoscopically, there is a clear of the tumor, and then you can do the stapling and take the specimen out as you would with intact presacral fascia. Specimen should come out looking very, very similar, boringly similar. And I think this is one thing that I try to teach my trainees. It's a specimen-oriented surgery, not oriented around the technique, that how fancy the technique looks. Because at the end of the day, this dictates how good or bad the cancer function would be. Abdominal excisions. A couple of slides about this. This is an important concept for people to understand. This has been a problem, distal rectal cancer, because positive margin.
Professor Amjad, we have 1 minute left, please.
Okay. You have 1 minute? I come to 1 minute. This is, you already have seen slides. This is complete clinical response. This is being done in Palliative Foundation. And the idea really is to do what we call a timeline follow-up. Every 4 months, patient have endoscopic assessment. If they have a complete clinical response, they have digital examination, and they have MRI scan. For the first 2 years, we do them every four monthly, and then increase it to 6 monthly. So this is the slide you have been waiting for. Seeking anatomical precision, full standardization of operative technique is the key. Attention to details and reproduction of operative technique holds the key. And I think with purposeful practice, you can demonstrate marginal gain. I'm very grateful for your kind invitation, putting up with me. Thank you very much for listening to me.
Thank you very much.
Thank you for all speakers for this long session. The stage is open for any question to any one of the speaker. أي سؤال؟ استفسار.
Thank you very much. I would like to ask a couple of questions. Actually, the first one is for Dr. Riyad. I think he's here. I encounter personally several cases of, for example, bladder cancer or upper tract TCC where I'm planning to operate. And as part of the staging scans, I do CT chest, abdomen, pelvis. And several times the radiologists, I think some of them, they are here now, they mentioned the presence of small, non-significant or equivocal nodules, which is around 5 to 8 millimeter in both lung fields, which we don't know exactly what are they, whether they are malignant metastasis from the bladder, or they are primary non-significant nodules or primary small lung carcinoma. And we bring this to our MDT, and most of the time we don't reach a conclusion. They mentioned that CT PET will not tell you exactly what are they. We can do biopsy because they are small and peripheral, and we have this long debate because, you know, in bladder cancer, for example, or upper tract TCC, if it's metastatic disease, the treatment is completely different if it's not metastatic, and we don't have much time to think. So what's your advice for this situation?
First, thank you very much for this very nice question and very important. Actually, this scenario is very challenging, and we face it many times, especially with the small nodules. You will try to see if this is like high probability of being cancer, like rounded, peripheral, in a very aggressive or large tumors. Then your suspicious will be high. Sometimes we go in and do VATS biopsy to make sure that this is a tumor, especially with the bladder cancers. In RCC, sometimes because you have a good medical treatment and there's a role of metastasectomy, then you can just leave it and see if it progressed, then you go and resect or give SPRT. If it's stay the same, and then you just watch it. Nowadays, with the digital form of the PET-CT scan, you can detect small nodules down to 5 millimeters, and you can see if there's any activity in it or not. I think if the patient is young, the surgery is tolerable by the patient, and you go for surgery and follow up this nodule. And if it progresses soon, then go for medical treatment. If there is like long disease-free interval, then do metastasectomy if this is the only one nodule. I see this as out of the box or a stretch in the treatment. But if you have long disease-free survival in a patient who is healthy and you can just stretch the treatment, then go and resect it after. If you develop another masses, then you just go and give medical treatment.
Okay, thank you. And just another small questions, similar questions about this. Is there any data about how much, what is the percentage of small, non-significant nodules that you may find in, for example, patient or an home like behavior above the age of 60? Like, what is the incidence of small lung nodules in elderly people?
I don't have exact number, but we face it, especially in the smokers. You have very tiny 2 to 3 millimeters, non-specific lung nodules, especially if it's bilateral. Then we just ignore it and follow it up, especially in the low-risk patients, and then goes for the definitive surgery and then assess the lung nodules after. So I will go this way, but I don't have exact number.
Okay. Thank you. Sure. Thank you very much.
Anyone have any question? Go ahead.
Anna, can I ask a question for Dr. Abdelrazak? Dr. Abdelrazak معنا? I have one comment and 2 questions, Dr. Abdelrazak. And thank you very much for the nice lecture. My comment, just if you do surgery and you do good hemostasis, then I don't think the prophylactic anticoagulation will matter. So don't blame the anticoagulation, just blame yourself. 2 questions regarding the prophylactic anticoagulation. What do you think about the long-acting prophylactic anticoagulation like the tenzabarin and the fondaparinux? Would you use it as a prophylaxis since it's long-acting like the fondaparinux?
Yeah. Sorry, can you just repeat the second part of the question?
So what do you think about the long-acting anticoagulation like the Tenza and the Fundabernics used in prophylaxis after surgery for the patients who had cancer surgery, for example?
Yeah, I think the, as you know, the post-operative period is the period where you could expect bleeding due to anticoagulation. And therefore, the shorter duration anticoagulation you can use immediately post-operatively, and depending on the surgery is ideal. Unfortunately, during my talk, I didn't go in details in the type of surgery where you have to be very careful in timing and choosing the post-operative anticoagulation. Generally speaking, most of the surgeries you can start anticoagulation within 12 hours after surgery, except spinal surgery, aortic aneurysm surgery. But again, if the risk of a thrombosis is high and the risk of bleeding due to surgery is also high, you would like to use a short-acting anticoagulation. Fundaberinox in itself is relatively long duration of action. And my personal choice and advice in this scenario to use unfractionated heparin, IV heparin, because you can monitor it, and if any unexpected post-operative bleed, you could switch off the machine and you can easily reverse it. You're right, some people do use a smaller or a prophylactic or intermediate dose of Glaxane, but doing that may compromise the efficacy of anticoagulation in terms of reducing the risk of thrombosis. These days we have more the short anticoagulation like Apixaban, which has short half-life, and I would, generally speaking, if it's not contraindicated, DOACs, in particular Apixaban, should be considered. If this answers your question.
Yeah, yes, thank you. The second question is about stopping the anticoagulation before surgery.
Sorry.
Yeah, the second question is about stopping the anticoagulation before surgery. So as surgeons, we fear of Plavix, warfarin, Apixaban before surgery, and we should stop it. You mentioned that you can stop it just 2 days before, or you just talking, you were talking about the Apixaban, because usually Plavix, we stop it 5 days before surgery.
Yeah. I think that's a very good question. It's the stopping before surgery is probably more challenging than after surgery. But it depends what anticoagulation you are using. Warfarin, if you want to, if a patient is on warfarin, which I suspect there is still a big number of patients with metallic heart valve and they are still on warfarin, you need to stop it 5 days before surgery and replace it within very strict protocol with unfractionated heparin. For the DOACs, we stop anticoagulation 48 hours before the surgery. And then, this is what I tell my colleague all the time, the timing to restart anticoagulation post-operatively is largely a surgical decision. And surgeons should always develop their protocol to classify surgeries, risk of bleeding or low risk of bleeding, because a lot of surgeries these days, they can be done without interrupting anticoagulation. For example, dental extraction, abdominal hernia, and in fact, some cholecystectomy. It is very important topic, and at the end of the slide that I did have some pro forma, which I didn't have the chance to present it, this is like any other good practice. There should be local protocols in place. And in fact, in my trust, we have individual pro forma filled at the pre-assessment clinic by the hematologist, surgeon, and anesthetist. And it times exactly when do you stop anticoagulation and when to restart it.
Thank you.
Thank you.
شكرا جميعا. Any question more? We have to move to the next. Now في break. Cafe break for 15 minutes or 20 minutes.
So thank you very much for this nice sessions. Thank you for the moderator for moderating this session, and thank you for the speakers. It was heavy, but it was really fruitful and very nice. I would like to invite quickly the Serge-Bal board in order to announce the winners of the 3 prizes from yesterday. So I would like to invite Dr. Mazen Abdullah, the president, Dr. Iyad Maqbool, Dr. Mazen Abdullah, Dr. Suhal Hamshri, and Dr. Abdul Karim Barqawi. And I don't think Dr. Khalil Isa is here, is he? No, he's not. So if you can come. So yesterday we have 3 competitions. The first one was the best podium presentation for the best research project in the first day of the Oncology conference. And the judges yesterday, Dr. Haytham Al-Hassan, Dr. Muhammad Ali Mbayyad, and Dr. Muhammad Abu Dhaher, they've marked all presentations after listening to the presenters and after reviewing the article. And I would like to announce that the winner for the best podium presentation is Nagham Kawa for her presentation. So I would ask Nagham to come. So Alf Mabruk. Sorry, for the poster. For the poster. عكستهم أنا بس يعني بنرد نعيد كمان مرة. So this is for the best poster presentation. آخر النهار بيطلع لي أتعب شوية. ألف مبارك. في صورة مني صورنا له الإعلان بتصورنا. Okay, so for the poster session was Nagham, and there were secret evaluators for that presentation. For the podium presentation, who was assessed by Dr. Mbayyad and Dr. Haytham and Dr. Muhammad Abu Dhaher, the winner is Dr. Hamza Hamayel. But he's not here. And also for the Health Cup, we have the Health Cup. Yes. Dr. Asma here. Would you please come here in order to hand over the cup? لا اسمع هي بدها تعطي الكب. لا بدهم ابو عزوز ظرف كمان. ظرف كمان. الفايز ظرف والكب. ظرف والكب. احمل الكب يا اسمع روح عشان سلميها. اعطيها الكب دكتور مازن. مش مشكله روحي. والله عادي انا بس بدي احكي بس الفكره نحكي عنها. Okay, so the winner is Ala Amir. Dr. Asma will just explain why she has won this.
We don't have English speakers صح؟ عشان احكي بالعربي عادي. الفكره كانت من الهيلث كاب تشامبيونشيب، وهي فكره دكتورها صفاء، شكرا لها، مش عارفه اذا هي هون تتفضل معنا. كانت to raise awareness for early detection of prevalent cancer. ما حددنا اي نوع كانسر، فسلكتد ايدياز كانت من طلاب، مش بس طلاب طب، كان في من كليه الطب، كان من التمريض، والاء كانت من التخدير والانعاش الفني. والكانسرز اللي اختاروهم كان بروستيت كانسر، سكرينينج فور بريست كانسر، وسكرينينج فور كولوريكتال كانسر. الافكار انعرضت امبارح والوينر كانت ألا، ألف مبروك إلها. الجادجمنت كان فيري كلوز شباب، فما تزعلوش كثير، شغلكم كان ممتاز، يعطيكم ألف عافية. ألا حابة تعرض فكرتها حتى تشوفوا ليش تم اختيارها يعني، فتفضلي ألا. الكنترول روم لو سمحتوا البرزنتيشن عندكم. البرايز as promised هي كانت كأس العالم، أو يعني صورة عنه اللي هي موجودة. والجائزة الأهم إنه your idea will be funded إن شاء الله، ورح تلاقي طريقة من فكرة على الورق إن شاء الله practical idea توصل للناس. فألف مبروك ألا.
يعطيكم العافية جميعاً. أنا الطالبة آلاء عامر، تخصص تخدير وإنعاش. أول إشي اسمعوا، أنا ما بدي أفحص، تمام؟ يعني بلاش يطلع معي كانسر، خليني مش عارفة أحسن لي. هلأ كتير بنسمع هاي العبارات وغيرها من العبارات بمجتمعنا. الناس على الأغلب خايفين، مش خايفين من الكانسر قد ما هم خايفين من إنه الكانسر، إنه الشخص اللي معاه كانسر خلص انتهت حياته. يعني بالنهاية هم خايفين من نظرة المجتمع، وخايفين كمان من إنه المعلومات المغلوطة اللي هم Next slide. لهيك بحب أحكي للناس اطمئن. هلا اطمئن هي حملة معنية بسرطان القولون والمستقيم، واللي هو ثاني أكثر نوع سرطان منتشر في فلسطين. طبعا مع انه ثاني اكثر نوع منتشر، لكن بنلاقي الناس ما بتعرف عن هذا النوع من السرطان، ما بتعرف عن اهميه الكشف المبكر في تحسين فرصه العلاج. الحمله بتعتمد بشكل كبير على صفحات السوشيال ميديا، اللي من خلال منشوراتها احنا بنقدم المعلومات الطبيه بلغه سهله وبسيطه لحتى توصل للناس. هون مثال. واللي بيميز الحملة كمان هو توفر مجموعات الدعم للأشخاص المقبلين على الفحص لحتى ندعمهم نفسياً، وكمان نجيب على استفساراتهم عن طريق أطباء مختصين في ندوات، وأيضاً مشاركة معهم قصص نجاح مرضى الكولوريكتال كانسر اللي هم كمان تغلبوا على المرض وانتصروا عليه. كمان الأهم شيء بالحملة هو التوعية على مدار العام عن طريق صفحات السوشيال ميديا، ولكن تكثيف التوعية في شهر 3 اللي هو شهر الكولوريكتال كانسر العالمي. وأيضا عمل وحدة فحص متنقلة اللي هي لفحص الدم الخفي في البراز بشكل مجاني، ورح تكون معنية أكثر إشي بالأشخاص اللي ساكنين بمناطق بعيدة عن مراكز الفحص، وكمان للأشخاص اللي ما بيقدروا يوصلوا لمراكز الفحص. وبالنهاية ولأن لجسدك عليك حق، كون أنت المبادر بالفحص المبكر وكمان اطمئن. يعطيكم العافية.
لا احنا طبعا بنشكرك جدا، فكره كثير جميله، وبنتمنى انه انت او الجروب تبعك يكتب بروبوزل عن الفكره الا وقديش ممكن تو بي فاندد، ويسلمها للدكتور مازن رئيس المؤتمر. Okay, so I would like to invite the new, we are now going to take coffee break, so I would like to invite the new moderators for the new session, Dr. Suhail Hamshari, Dr. Iyad Maqbool, and Dr. Rashel Khayyat, to moderate the MDT session, which is the most important session in oncology, sessions. Dr. Rashel, لو سمحتي? No coffee break, so you can just grab your coffee. خلص ما بيجيش من اول احنا. Okay.
Okay, so we'll move to the next session. Faris, do we have 5 minutes coffee break? Okay, 5 minutes and we'll start. Okay.